Okay, so this screencast is on aging-related and cognitive disorders, and I want you to think about the brain. The brain is, like a 3-pound lump of jello encased in your, hard and rigid skull. And that brain is delicate, and it can be injured. Not only that, the brain wears out. And I would imagine that most of the students in the class at some point have actually had a brain injury. You might not have realized it, but I'll bet you have. Like a concussion would be a great example. That's technically a brain injury. I mean, you can have a concussion and not really worry about it. But the accumulated damage of concussions can be really detrimental to your cognitive health, and especially if you're getting concussion on top of concussion on top of concussion, like let's say a football player. So if we're lucky enough to live to a ripe old age, we are likely going to have some sort of cognitive dysfunction, because basically the brain isn't meant to last that long. And as we see increase in life expectancy, we also see an increase in aging-related disorders. So let's talk about some of these and the nature of cognitive disorders. Now, the specialty field of neuropsychology or neurology are going to deal with cognitive disorders. So a neurologist is a medical doctor that specializes in disorders of the brain, and a neuropsychologist is a psychologist that also specializes in assessment of disorders of the brain. So the brain can be injured in a number of different ways. Obviously, trauma. So, you could get in a car accident and hit your head against a windshield, slip and fall on some ice, you get hit in the head by a baseball, gunshot wounds, all sorts of things can injure the brain. That's one reason why I think wearing helmets is very important. Oftentimes my students make fun of me for recommending that they wear a helmet while they drive, but you really need to protect your brain against injury. I mean, I like to do a lot of activities that you could potentially have a head injury while participating in, like skiing and snowboarding and mountain biking, stuff like that. Always, always, always wear a helmet. And if you're a parent and you have a kid, make sure that your kids wear helmets, because preventing brain injury is easy, and dealing with a brain injury is very, very hard. So you can also have diseases of the brain, whether that's a bacterial or viral infection like meningitis. You can have parasites or fungus that attack the brain, mold, stuff like that. There's lots of different diseases. The broad category of disease is called encephalitis. So encephalon means brain, itis means disease. And then you can have meningitis, which would be like an infection of the meninges, which are the covering of the brain. The meninges consist of the pia, the arachnoid, and the dura mater. And then you can expose your brain to toxic substances. And there's lots of different substances that can be toxic to the brain. I want you to note here it says drugs, not so much like illegal drugs. I know we have the idea of, like this is your brain on drugs, take an egg and smash it with a frying pan. It's not like that. If you're a developing fetus and you're exposed to drugs, probably a whole lot worse for you, but there's lots of other drugs that can really seriously cause brain damage. And neurotoxins. So some drugs are specifically neurotoxic, and they can take out localized areas of the brain and or cause diffuse brain damage. There's all sorts of chemicals in the environment that can cause brain damage. For example, lead, mercury, stuff like that, not good to have in the environment. And unfortunately, lead paint is common in places that were built before the 1970s. Will have lead paint, and you don't want to eat that. Mercury is in fish. There's lots of different contaminants. Okay, so when we look at the different diagnoses, I want you to remember these three broad categories. So you have delirium, dementia, and amnesia. Okay, and we will differentiate and define these three categories. So let's start with delirium. What does that mean? I'll bet you've heard the term delirious. There's a Eddie Murphy comedy special named Delirious. What does that actually mean? So delirium is a temporary, note that, underline it, whatever you got to do. It's a temporary state in which an individual experiences a clouding of consciousness. So they're going to have, their consciousness is going to be impaired. An individual that is delirious may be unaware of what's happening around them. They may be unable to focus or pay attention. Following a head injury, someone may be delirious. Let's say you're playing in a football game and you get rocked. Maybe helmet-to-helmet contact or something. And I've talked with professional NFL football players that have described this experience, that they get just nailed in the head, and then they don't know what's going on around them. They're completely out of it. So that's delirium. That's gonna go away, and you will return to a normal state of consciousness. And delirium happens for a number of reasons. If you take somebody and give them, I don't know, half a bottle of Jack Daniels or something like that, they're gonna be delirious. So you can be intoxicated, and that can cause delirium. And substance withdrawal can actually cause delirium. Let's say that you are a chronic alcoholic, or we could do heroin addict or something like that, and you've been using those substances regularly for a long, long time. You've developed tolerance. When you go through withdrawal, you may experience delirium. There's a condition called delirium tremens, or DTs, that's associated with alcohol withdrawal. Head injury, we talked about a concussion or a football player. High fever. Actually, I don't like to fess up to this too much, but when I was a young kid, when I would get a high fever, I would get delirious. And it just happened a couple of times. But I remember those periods of delirium very, very clearly. And I can attest to having radically altered consciousness. So when I would get a high fever, I would be completely out of it as a kid. And it would almost seem like a dream state. So my parents report that was kind of scary for them, but that can happen. And then vitamin deficiencies can cause delirium. Mineral and electrolyte imbalances in the body can cause delirium. Infections can cause delirium. There's all sorts of different things that can cause delirium. But the key thing to remember is that it's temporary. Here, again, causes infection. Central nervous system disorders can cause delirium. Metabolic disorders. There's a delirium rating scale. Treatments here. It says the pharmacological approach. There are drugs. You use antipsychotic drugs typically, or benzodiazepines, which are anti-anxiety drugs. And if somebody is delirious, let's say somebody is intoxicated on methamphetamine or something and they've become delirious, you can use medication to counteract that. So you give them a shot of haloperidol and Ativan mixed together, and that can treat delirium. Risperidone is another antipsychotic drug. Haldol, the generic name is haloperidol. There's lots of different drugs that you can use to treat delirium. But really what you want to do is understand the underlying cause of the delirium and treat that, because the delirium will then go away. And if you just treat the symptoms, the underlying cause of the delirium will likely persist and you will continue to have delirium. So you want to treat the infection. You want to treat the metabolic disorder. All right, amnestic disorders. That's like amnesia. So amnestic disorders are cognitive disorders that involve the inability to either recall previously learned information or register new memories. Sometimes when it's the inability to recall previously learned information, think about that. That's information from the past. We call that retro, like retro, going back. Think retro clothing, back from the 60s or something like that. We call that retrograde amnesia. And when it's in the future, I always think of that term is antero, and I always think of an anteater for some reason, and their nose is pointing ahead into the future. So the inability to register new memories, we call that anterograde amnesia. Sometimes you can have both. There's different categories of amnestic disorders. There can be chronic amnesia, where the amnesia lasts for a very, very, very long time, or transient. Sometimes that's called like acute, and that the amnesia will come and go. There's also substance-induced persisting amnestic disorders. Alcohol can interfere with memory, like with Korsakoff's syndrome, stuff like that. Medications can cause amnesia. There are a whole host of medications that can cause problems with remembering things, and actually these problems can be exacerbated in the elderly because they don't metabolize the medications quite as well. So something as simple as Benadryl or diphenhydramine. Benadryl can cause problems with memory. The anti-anxiety medications, the benzodiazepines, can cause problems with memories. Actually, the drug Rohypnol, sometimes referred to as Rufinol, that sometimes is used as like a date rape drug, specifically when combined with alcohol, because it will interfere with your ability to form new memories. So that is a medication that can cause memory problems. Illicit drugs can cause memory problems as well. Lead, mercury, insecticide, industrial solvents. But really, the most common cause of problems with memory is chronic, heavy alcohol use. Okay, traumatic brain injury. Sometimes we refer to a traumatic brain injury as a TBI. Maybe you've heard of that, but TBI is damage to the brain that's caused by trauma. So I've referenced concussion a lot. Following like a head injury, you can have post-concussion syndrome, which is a whole constellation of physical, emotional, and cognitive symptoms that really can last just a short period of time. And then here to years, I want you to note that one of my professors at Nova Southeastern University, his name is Wiley Mittenberg, if you want to look it up, did some really interesting research about post-concussion syndrome. And he found that people whose symptoms last longer than a year are typically involved in litigation. So there's some sort of lawsuit. But it'll usually go away within a year. So I want you to think about what happens. Imagine, let's say like a baseball came flying in here, and the baseball would strike the skull right there. That skull protects the brain. Think about the skull as being like a helmet. And then the skin around your skull actually kind of slips, which helps protect the brain as well, because it dissipates some of the force. But you have the strike, and you'll have an injury here. And we call that a coup injury. That's C-O-U-P. And that coup injury is at the point of impact. Think about, you could hit your head on a window or something right there too, like in a car. If you hit a deer or something and you weren't wearing a seatbelt, you could hit your head on the windshield. But then that force travels through the brain. Remember that the brain floats in cerebral spinal fluid inside the skull, and it'll kind of slosh back over to the other side, or you might have like a whiplash and your head will like flop over the other way, and the brain will impact the skull on the opposite side of the coup injury, and we call that a contra coup injury. Think about like twisting and torsional forces and being tackled and stuff like that. Go down to the neuronal level, and remember that neurons are connected to other neurons through synaptic connections, and those dendrites that reach out and make connections with the terminal buttons of the other axons. I mean, that's super microscopic thin fibers, and they're very fragile, so you can have tearing of those fibers, and that would be a brain injury that you're not going to see on any sort of CAT scan or MRI or anything like that. Okay, dementia. You've probably heard of the term dementia. I mean, it's just a reality that if you have grandparents that are alive, you may have a grandparent with dementia, because dementia is very, very common. But what is dementia? So dementia involves a generalized progressive deficits in a person's memory. They have the inability to learn new information. You can have disruptions in the ability to communicate, problems with judgment, and difficulties with motor control. So dementia is this huge category of disorders. There's a huge number of things that can cause dementia. Unfortunately, dementia, in contrast to delirium, is likely going to be a chronic, progressive disorder that you're not going to be able to get rid of. And there's all sorts of different things that can increase the risk for dementia. Now, again, I want to say that there are a huge number of things that can cause dementia. And like, for example, Alzheimer's disease is the most common cause of dementia. However, there's all sorts of other types of neurological disorders that produce dementia. And if we look at the factors that increase the risk for dementia, a lot of these are unique to American culture. And usually at this point, I'll have a student that will say, but Professor Silk, haven't you seen that there's the lower rates of dementia in Japan, and it's because they eat so much fish? Well, it's not necessarily that they eat so much fish, although that might be correlated to lower levels of dementia. There's a lot of different things. And I want you to think about like modern American lifestyle. So cortisol is a hormone that's released during the stress reaction. So those two things are about chronic stress. I don't know about you, but my lifestyle is pretty stressful. Genetics. So there is a genetic component to that, especially Alzheimer's disease. There's a subcategory of Alzheimer's called early onset Alzheimer's, highly genetic. But other disorders like Huntington's are basically purely genetic. So it can go from, you know, a small amount of genetic contribution to almost all. Sedentary lifestyle, you know, living your life as a couch potato, that's not good. Blood pressure problems, problems with blood sugar like diabetes, an increase in belly size. You know, that fat around your chest and belly, that's the bad kind of fat. You don't want to have that kind of fat. And then chronic inflammation. So in the DSM, there are symptoms of dementia, and in order to receive a diagnosis, the individual must have memory loss as well as one or more of the following 4 symptoms. So you have to have memory loss, but then the other 4 are aphasia. So let's say that aphasia is the inability to understand or produce language. When you see that, it's really fascinating. So there's Brokaw's aphasia, that is the inability to produce language. And then Wernicke's aphasia is the inability to understand language. Sometimes individuals can have both. Apraxia is an inability to carry out motor activities despite intact motor functioning. Agnosia is the inability to recognize familiar objects or experiences despite the ability to perceive their basic elements. So like if you hold up a watch and show somebody a watch that has Alzheimer's disease and you say, hey, what is this thing? They might have great difficulty telling you what it is. They kind of know what it is. They might go, oh, it's that thing that you wear on your wrist to tell time. But they might have trouble naming it. And that's called dysnomia. Disturbance in executive functioning. They might have an inability to plan, organize, or sequence activities, and have the loss of abstract thinking capacity. And in neuropsychological evaluations, these are the things that we test for. There's Alois Alzheimer, who Alzheimer's disease was named after. He was the first person to describe Alzheimer's disease. Alzheimer's is a progressive and gradual cognitive decline due to severe cerebral atrophy. And this film, The Forgetting, you'll have a link to this in your class. It's hard to watch, but it is recommended viewing for the class. And that'll give you a glimpse as to what Alzheimer's is actually like, and you can see the various stages of Alzheimer's disease. Alzheimer's disease is a really awful disease, and it's incredibly hard to see someone go through Alzheimer's disease. So early Alzheimer's not so bad, But as you get into the middle and then progress into the late stages of Alzheimer's disease, it's really a horrible disorder, and there is no cure for Alzheimer's disease. We have some medications that can help, but it won't stop the disorder, so we don't know. And here's a little chart, and that this yellow line is healthy aging, and as you age, at about 30 is when you start the downhill progression. Okay, so I mean, we're just gonna have that decline, and then, you know, prior to death there's typically a sharper decline. But in Alzheimer's disease, what happens is that you'll have changes in the brain early on, and right now drug companies are pursuing different methods of identifying the changes in your brain prior to the onset of the disorder. So theoretically, you might be able to intervene at that point, but I mean, that is well down the road. So as you come along, you have what we call mild cognitive impairment. And so here you have some memory problems. And other than that, your cognitive functioning is okay. And we all have those memory impairments where we have mild cognitive impairments. I mean, I'm back here, but I still have those moments where I forget stuff that I should not be forgetting. But your brain is able to compensate for that. So as you take the path down of mild cognitive impairment, the cognitive decline accelerates, and then at some point you'll meet the criteria for Alzheimer's disease. After the diagnosis of Alzheimer's, it is a progressive decline in functioning. So you'll have early, middle, and then late Alzheimer's, and unfortunately at the end you'll have a total loss of independent functioning. If you take medications for the disorder, it can kind of slow the progress. So instead of following the blue line, it might kind of go down like this if you watch the cursor, and you might have a just a delay in the inevitable symptoms. Okay, there's all sorts of other types of dementia other than Alzheimer's disease. And there's physical conditions and toxins that can cause that. Infectious diseases can also cause the changes that occur with dementia. So what we typically have is that there's going to be life influences like genes, environment, or systemic factors, plus damaging processes occurring before the symptoms appear. And we've identified all of these things. I'm not really going to go through them because in this class I don't really care about that. In the biological basis of behavior, that's more important. And then you'll see the early symptoms of the disorders, and we call these neurodegenerative diseases. You know, the major one is Alzheimer's disease. And then if we look at some of the other ones, you will see overlap between them. But you can have Alzheimer's disease and Parkinson's disease. There's a disease called Lewy body dementia, or dementia with Lewy bodies. There is Parkinson's disease with dementia, and then kind of without over here, just regular Parkinson's disease. FTD is called frontotemporal dementia. That used to be called Pick's disease. Is amyotrophic lateral sclerosis, or Lou Gehrig's disease. That's just a terrible, terrible disorder. And then MID is multi-infarct dementia, which is also known as vascular dementia. That comes from having a number of small strokes, mini strokes, which we call transient ischemic attacks or TIAs, and the cumulative effect is multi-infarct dementia. Those are just a few. So Pick's disease, that's frontotemporal dementia. Parkinson's disease, you kind of have dementia with Parkinson's disease. Lewy body dementia, that one's kind of interesting because you'll have hallucinations associated with that. Frontotemporal dementia, that one's interesting. You'll see like really inappropriate behavior accompany the dementia. So like grandpa's gonna get like really, well, it doesn't always happen this way, but he may get potentially like very sexually inappropriate stuff like that. I have friends that are physicians, and they always miss frontotemporal dementia, and they think it's funny. And they'll say, oh, you know, I had this 85-year-old woman try and pick me up in the emergency room. And I'll ask them a couple more questions, and then, you know, they're laughing, ha ha ha, she was trying to get in my pants in the emergency room. And I mean, this is not a joke, this is really serious. And they miss the diagnosis. That's actually a symptom of frontotemporal dementia. Huntington's disease, Creutzfeldt-Jakob disease or mad cow disease, and then vascular dementia or multi-infarct dementia. Parkinson's disease, there you're going to see a lot of motor functioning problems. So you might see tremor or shaking. You're going to see muscle rigidity and difficulty initiating movement. Bradykinesia. Brady means slow. Kinesia means like kinesthetic, means movement. So you'll see a slowing of movement. I wish I could get up and walk around in front of you. But the way to identify Parkinson's disease is you look at the individual, and there's lots of different things that can cause Parkinson's-like symptoms. So this is just how to identify the symptom. You watch somebody walk. The first thing is they'll be devoid of arm swing. So their arms are going to be right by their side. And then their legs are going to be about shoulder width apart. And they're going to have this kind of slowed, shuffling gait. They're not going to walk like smooth and fluid. And then if you ask them to turn around, instead of pivoting like on one foot like we would do, they kind of like do like a turn. They kind of go left, right, left, right, left, right, left, right, left, right, and kind of turn around that way. It's really interesting. You might want to Google some videos on that. Some people with Parkinson's disease have difficulty starting or stopping movements, like walking. They'll get stuck. I know this sounds terrible, but if you kind of give them a push, or with Parkinson's disease, if you put like a broom in front of them, like you're going to trip them, it can initiate the movements. It's fascinating. It's really interesting. And then you'll see cognitive deterioration. Their face, you have what's called facial masking. Their face lacks expression. Sometimes, like old school, they would call that a reptilian gaze. And so you'll see like their face looks like they're wearing a mask, no emotion, and their speech becomes stilted. There's also pseudo-dementias, which are really interesting, false dementias. That's why neuropsychological evaluation is very important. And you'll have symptoms that are actually caused by depression that mimic those in early stages of Alzheimer's disorder. So it's very important to differentiate between depression and Alzheimer's. And the diagnosis of Alzheimer's, brain imaging techniques work best in later stages of Alzheimer's because you will see atrophy of the brain, but this is not how you diagnose Alzheimer's. So scratch that out. Maybe someday, but not now. What we really do is neuropsychological testing, because It's the only way to diagnose Alzheimer's disease. You can do a brain biopsy. I mean, you could go in there, take a bit of brain tissue, and you can see the characteristic histological changes of Alzheimer's disease. However, I think there's only one hospital in the country that does that. I think it's Duke. There's all sorts of guidelines for the evaluation, just so you know that. Things that we follow when we do evaluations, and we use a mini mental status examination. The NINCDS is the National Institute for Neurological Communication Disorders and Stroke. And then ADRDA is Alzheimer's Disease and Related Disorders Association. They have Alzheimer's criteria, and they specify 8 cognitive domains that may be impaired in Alzheimer's disease, including memory, language, perceptual skills, attention, constructive abilities, orientation, problem solving, and functional abilities. And the neuropsychological tests that we use, we basically test all of these areas to see if there is in fact impairment. So the biological features of Alzheimer's disease, I'm not going to go into this too much. I'm going to show you some pictures and really not describe what's going on. But if you're interested in this, I mean, look this up. It's really fascinating. But there are neurofibrillary tangles and amyloid plaques that accumulate in the brain tissue. Those are like those changes that you can see when we look at brains of Alzheimer's patients after death. And there's risk factors for Alzheimer's disease like cigarette smoking, obesity, lack of exercise, and then again, genes play an important role as well. So you can see those changes. There's a neurofibrillary tangle right there, composed of tau fragments, and you have beta amyloid plaques that are formed as well. And if you're interested in that, go to the book and read about that. There's all sorts of types of drugs for Alzheimer's disease. Basically, there's 2 main categories. One works with NMDA, or N-methyl D-aspartate. It's an antagonist drug that is prescribed to treat the symptoms of moderate to severe Alzheimer's. And so what happens here is that glutamate in excess can be very toxic to the brain, and so it blocks glutamate NMDA receptors. So that drug is called Namenda or memantine. So that's one category. The next category, all the other drugs are going to be drugs that increase acetylcholine. So they're all cholinesterase inhibitors. Cholinesterase is an enzyme that breaks down acetylcholine. So if we inhibit cholinesterase, you can increase the levels of acetylcholine. And so Razidine, Exelon, and Aricept, they're all cholinesterase inhibitors. And there's all sorts of side effects for these two. Again, nothing can cure Alzheimer's disease, unfortunately. These drugs can only treat the symptoms, and even then, it's just they kind of slowed the progression of the disorder just a little bit. So there's lots of behavioral strategies that we can use. I mean, Alzheimer's disease, think how hard that is on the family. Potentially you've experienced it yourself. I mean, I have, and it's just a hard disorder to deal with. Someone might require 24-hour care and may not be able to perform basic activities of daily living. So we want to target both the patient and the caregiver. I mean, you don't really necessarily want to do psychotherapy with the patient with Alzheimer's disease. I mean, and this is not a joke, but I mean, if you do therapy, they're not really going to remember what's going on, but the interventions are different. So what we want to do is increase patient independence and make things easy in their life for them to continue to function on their own. We want to protect the individuals and eliminate wandering and aggression. And we want to definitely provide social support for the caregivers, because this is an incredibly stressful disorder for the caregiver. It's really tough. I mean, frankly, it's a hard thing to deal with. So that's it for this screencast. You know, we are just scratching the surface of the aging-related disorders. There are a lot more disorders that we didn't even cover. So if you're interested in this, you know, continue exploring further. If you like this area, you know, consider further readings in neuropsychology or neurology. I have 2 authors that I really like that write about neurological disorders. One is Oliver Sacks, and the other one is V.S. Ramachandran. Both of them have written numerous books about different neurological disorders, and they oftentimes write about aging-related and cognitive disorders. So check those out for further reading. If you have any questions, let me know.